All right, so my talk is going to be on genital arteritis. Vasculitis might be one of the most boring things that we learned about in med school, but there are some definitely important topics to cover here. So I'll just start with a case. 72-year-old comes in. She's had some subjective fevers, a mild headache for a couple days. Not really febrile in the ER. Vitals are okay. Had a mild non-productive cough. Says something about her vision going dark a few seconds, maybe a few minutes yesterday, but now is normal. And her exam is completely normal. You see this patient in the ER, your suspicion for something bad going on is pretty low. And the reason I highlighted this case a little bit is not to have you guys guess what the answer is. The answer is here. But it's more to show you how vague these symptoms can be. So just some basics about genital arteritis. It's vasculitis of the large vessels, so the aorta and the great vessels and the vessels coming off of them. Usually, like all vasculitis, is inflammation due to cytokines, specifically arteries of the cranial branches. So the other thing is there is an association with polymyalgia rheumatica, which is big joint pain that you can get. There's different diagnostic criteria for it. But around 50% of patients who have genital arteritis also have this condition. Epidemiologically, so lifetime risk, 1% lifetime risk in women, 0.5% in men. And it's almost never diagnosed before the age of 50. I think there have been 2 case reports or something. But for the most part, it's after age 50 and peak incidence in the 70s. And the highest ethnicity is among Scandinavian, Northern European populations. So, in terms of symptoms, so a lot of the symptoms are very vague or not super severe. So, systemic symptoms, you can get fever, fatigue, weight loss, things like that. So the fever usually only occurs in about half of the patients who come in. It's usually low grade. And then they've actually done studies that show 1 in 6 fevers of unknown origin in older adults is usually due to this condition. The headache only occurs in about 2/3 of patients. So one of the issues with diagnosing somebody with this condition is there's nothing pathognomonic about the presentation, and there's nothing, you can see like all of these symptoms that are the most common, only about 50% to 2/3 of patients actually have them. Jaw claudication is one thing we learn about for the boards especially. It happens in only about 50% of patients also. And then there's other issues with the large vessel. You can get aortic aneurysms, aortic dissections, etc. But these would also come in with their own presentations, with their own symptoms. And in most of these conditions, people come in with these symptoms, it's not a can't-miss diagnosis. There's only a few things that do make this a can't-miss diagnosis, but you send somebody home who had mild headache and a low-grade fever, and it actually was genital arteritis. There's nothing that says that they're going to come back suddenly with vision problems. And that's the one thing we really worry about with this disease process is vision problems. So there's the temporary and then the permanent. So temporary, it's a transient vision loss. It's usually monocular. Usually it's like an abrupt partial field defect. This can be a harbinger of permanent vision loss. I don't know about you guys, I see a lot of patients who come in, they say, oh, I've had a headache for 4 days. You ask them about vision problems, they say, yeah, I think my vision may have been a little off yesterday, I'm not really sure. That's happened to me like twice yesterday. So it's a vague symptom, you don't always get it. You have to kind of be very targeted about asking it. In terms of the permanent vision loss, this is the major problem with this disease process. So it's the most feared complication. It's usually sudden and painless. It can be partial or complete. It can be unilateral or bilateral. Within 1 week, the other non-affected eye, around 1/4 to 50% of patients end up with vision problems in that eye also. So this is caused by vasculitis of certain retinal arteries. So the most common is the anterior ischemic optic neuropathy. So this is permanent vision loss, or 80% of permanent vision loss in GCA is caused by this condition specifically. It's the main arterial supply of the optic nerve. So there's different anatomical presentations, but in general, you got to do a pretty careful, you have to ask targeted questions about vision loss, especially if it's transient vision loss, and figure out exactly where it's coming from. On physical exam, again, nothing super impressive about the exam for the most part. You may have diminished pulses. You may hear bruits. People make a lot of focus about the temporal artery. They'll have like a prominent pulsation or an absent pulsation, but again, it's not actually all that commonly seen. On the eye exam, the fundoscopic exam can be entirely normal. You can have some cotton wool spots, but again, nothing is 100% with this process. And then you will get you also can get an afferent pupillary defect, which a lot of times I think it's a little hard to describe, but it's basically a dilation of the pupil when you shine a light into the other one. You guys can go over that a little bit later. In terms of the diagnosis, so this is a bit of the hard part. There's no test. There's nothing specific about the physical exam. A lot of people talk about these 1990 criteria released by the American College of Rheumatology. So there are these 4 criteria: age over 50, new onset of a headache, temporal artery tenderness or decreased pulse, an ESR over 50, and then the last part is a biopsy, which is the only way to really diagnose this complaint. The issue with these criteria is they were released to differentiate giant cell arteritis versus other vasculitis in a patient with known vasculitis. This isn't for an undifferentiated patient in the ER. You can't really use these criteria. This is a clinical diagnosis. You just have to use your gestalt. This table didn't come out too well, but you can see that these are the different likelihood ratios for certain symptoms. So jaw claudication, a beaded temporal artery, that's a physical exam finding that you can get, and a enlarged temporal artery. Those are the most common things that you'll see, but again, nothing is 100%. Before we talk about treatment, I'll just talk about who you can't miss. And the ones you can't miss are the ones with vision loss. The people who complain about the transient vision loss yesterday, vision is completely normal today, they are at risk for getting permanent vision loss within the next week or so. The treatment is steroids. If the suspicion is high, and again, this is a clinical diagnosis, you're going to start them on the equivalent of 40 to 60 milligrams of prednisone daily, or you can use Solu-Medrol. For vision loss treatment, you use an IV pulse dose. And then they also low-dose aspirin. In terms of the prognosis, so most of the symptoms are self-limiting. They come, they go, nothing is permanent. Vision loss, which is the main symptom that we care about, a lot of these patients end up having permanent, partial, or complete vision loss, and the main risk factor being age over 80. And then the other issue is that they are associated with higher risks of cardiovascular disease, and again, these are older patients that you'll see coming in with this problem. And that is it. Any questions?